session today. I hope hello. Is everyone here? So we'll start with the session. I hope that you all are refreshed and re-energized after this amazing lunch. We now move into audiological track featuring a topic that is both clinically relevant and deeply significant in today's pediatric audiology. Auditory evoked potentials in pediatric audiology, neural markers of auditory development from cradle to classroom. This session focuses on the journey of auditory development. It promises to offer valuable insights into how these neural markers support both diagnosis and understanding of long-term auditory development. Her areas of interest include auditory processing disorder, auditory evoked potentials, and diagnostic audiology. With her expertise and experiences in this field, we are certain today's discussion will be highly insightful and enriching. With that, I now invite Ms. Richa Vivek ma'am to kindly take the session forward.
Thank you, Isha. This topic was something that we found after a lot of deliberation and a lot of discussion that what is it that we can cover that will reflect all of our areas of interest and still be something that can give a good take-home message. I hope you do enjoy this because all the five of us have worked in very separate areas and we've tried to amalgamate it in one topic. So we have, these are the speakers. I'd like to introduce them. Mr. Riaz Melin is an MSc Audiology from BVD USSLP. He is currently working in Mumbai as a clinical audiologist. His areas of interest are auditory potentials, diagnostic audiology, and he has done a few papers at Ishagon as well as done a dissertation specializing in auditory potentials. Ms. Shruti ma'am, just one second, I'll just maximize this. Ms. Shruti ma'am has done her master's from BVD USSLP and has submitted her thesis recently. She has worked in very different settings, multiple different types of setups and brings experience from multiple different types of setups. Her PhD focused on newborn hearing screening and ABR in infants, especially premature infants. Ms. Kutsia Khan is an audiologist working at Sabi Hospital and Research Center, Mumbai. Her areas of interest include electrophysiology, diagnostic audiology, and she has certification, she has done courses in MATLAB as well. Ms. Aditi Kothari, actually I cannot read this word. Ms. Aditi Kothari has finished a bachelor's from Bharati Vidyapeeth School of Audiology and Speech Language Pathology, and her areas of interest are cochlear implantation and EABR, which she will be talking about today. To move on, I'm sorry, this is a little slow. Alright. So I want to give a small introduction about this topic and what it is that we are going to be talking about. So when we're talking about it's slow. Okay. So when we're talking about development from cradle to classroom, we are speaking about the pediatric population. In the pediatric population, this is a general protocol for assessment of hearing. We have detailed case history, including perinatal, prenatal history, developmental milestones, behavioral tests which check responses to verbal tones as well as speech sounds, which are an indispensable part of the test battery. It can be in any form. It can be a BOA, it can be a condition play audiometry. If it's an older child, they will also be able to do PTA. Then, very important, speech audiometry to see speech perception abilities, and autoacoustic emissions and imittance evaluation. These usually consist of a routine test battery. Now, auditory evoked potentials are also part of the test battery, and in many cases we consider it an indispensable part when we are assessing a pediatric population. It is an indispensable part, but it is not, like, this is a disclaimer which I think all of us are going to carry, that electrophysiological tests are not exactly a full replacement for behavioral tests. You cannot do electrophysiological tests and say that, okay, I will not do behavioral tests because I have all the information. They are always used to complement behavioral tests, and behavioral tests do complement electrophysiological tests as well. So, when we are talking about auditory evoked potentials and development, we know that as the auditory system matures, the maturation takes place from periphery to center or caudal to rostral. So the peripheral auditory system matures, undergoes myelination earlier, followed by the central system. So it goes from the auditory nerve to the brainstem, to the subcortex and to the cortex. Now, if you talk about all AEPs, including early, middle and late, as well as discriminatory potentials like MMN, P300, N400, etc., maturation takes place from birth till 18 years of age. Auditory evoked potentials are a very good tool to study to objectively see the visual indications of maturation of the auditory pathways. Of course, we assess the cochlea, auditory nerve, brainstem and central auditory nervous system. It is associated with improving sound processing skills, like the markers that you are being able to see are associated with, can be associated with behavioral correlates like listening skills as well. We are able to see these markers and not make an exact correlation, but have an idea of the speech language development that may be, language and communication development that may be possible. After birth, myelination takes place rapidly, which is why you see a steep growth in development of ABR responses. The other potentials, however, continue to develop more slowly. Okay? So brainstem and cortical evoked potentials can be used to monitor this auditory maturation. As we know, latencies decrease and amplitudes improve, morphology improves with maturation. So this waveform, I think everyone has seen. This is from Handbook of Auditory Evoked Potentials by Hall. This is not something we've seen clinically because, of course, we don't have that kind of a sampling rate to see ABR, MLR, NLR in one waveform. But like you can see, the ABR waveforms will be the first to mature, followed by the MLR and then the LLR. The B and P1 components, by many authors, they do say that they are overlapping, or they have very similar and close generators, which is why it's not known. So auditory evoked potentials, when we're talking about it, the reason why I'm saying it is because in the further presentations, you will come across many different names. So they are classified according to cycle generation, latency as early, late and middle latency responses. The stimuli used, it can be chirp evoked, click evoked, speech evoked. It can be because of the modulated tones. So that is classification by stimulus. Of course, there is endogenous and exogenous responses. Obligatory potentials are what you saw in the last diagram. When you give a stimulus, if the auditory system is functioning properly, you do get a response. But discriminatory potentials are those, or the endogenous potentials are those which require some processing, some participation, some involvement of the patient himself. Okay, so we'll discuss those as we move further. And there are near field and far field potentials. The reason that I'm discussing this is because in the data presentations we are trying to discuss all of these. Briefly, I'll talk about developmental maturation. We know that the cochlea matures around 20 to 21 weeks of gestation. After that, the cochlea duct, the hair cells develop around 24 weeks, and the auditory nerve attachment happens almost at the same time, around 24 to 26 weeks. So, most births that are there are usually not earlier than 28 weeks of gestation, even in premature babies. Generally, they say that you get good responses after 32 weeks of full gestation, but theoretically, if we see, we can get an ABR by a very early, like even in premature babies, we can expect some ABR responses, especially wave 1. So there is a lot of discussion saying that, oh, but it's the baby is very young, will we get an ABR? Yes, we will. We will at least get some components of the ABR. Now, ABR does continue to mature till about 18 months of age, which is why we need to use a lower repetition rate, because the myelination is not complete till about 18 months to 24 months of age. Only in cases of auditory maturation delay, there might be a delay in this maturation. Okay, so 1 to 2 years and till about 18 to 24 months, you will see morphology which is adult-like. So what does that mean? You will see all peaks 1, 3 and 5. The amplitude ratio, which is there, like wave 1 to 5 ratio, is higher. So wave 1 is higher in amplitude than like the amplitude ratio. You see amplitude of wave 1 to wave 5 is higher in infants as compared to that in adults. All these parameters become more adult-like in morphology by around 24 months of age. Latencies become shorter, amplitude becomes better, especially for the later peaks. The interpeak latency also starts becoming more regulated, because initially the wave 5 is more delayed, whereas the earlier or more peripheral peaks, that is wave 1 and wave 3, may have shorter latencies in comparison. MLR, I will not discuss much because it is not used as much clinically. So MLR does take a bit longer for maturation, around 6 to 12 months, but your PA components can be seen around 3 to 6 years of age with good movement. PA and NB components can be seen a little later with maturation. So this is one article which we found for where they have assessed FFR responses in children. So they have found that FFR responses also, so frequency following response of speech ABR is a response to, are you able to just answer this? Okay, I can actually move. So this is evoked with a speech stimulus, where this is the transient part and this is the sustained portion. So here they have actually assessed FFRs for a 3-year-old, 4-year-old, 5-year-old, 6-year-old till 8 years of age. And what they have found is that the neural timing and synchrony have improved. The number of trials required to get a good response reduce, and also you get better amplitudes for the parameters that they're talking about, that is F0 and F1 and so on. Maturation of LLR, I will again talk in detail in my presentation, but maturation of LLR is something that we, to be honest, it is a very beautiful phenomenon that we actually get to see. If you have a slightly older child coming to you for auditory training or rehabilitation or even fitted with the CI. So this is your adult and P1 and 1, P2 and 2. But in a child you will see that there is no P1 and 1, P2 and 2 that is typical. You will see one peak and a trough. So these are a little difficult to interpret unless you have a little bit of practice. But eventually what happens is the latency goes on becoming shorter, and eventually you will start seeing a P1 here and a small P2 here till the responses become more adult-like. So adult LLR consists of a smaller P1, N1 and a large P2. Newborns and infants have a large PN complex, and it starts to differentiate as age advances. So here this is the same thing that you're seeing. You have P1, so a young child will have P1 and 1, and P1 and 1. That's eventually you start seeing one P2 here, and then it starts to mature like P1 and 1, P2 and 1. talking about so many APs, which AP to use, why we're talking about so many APs. My teacher, Dr. Sandeep Maruti from ICH, always said that for every behavioral test, there exists an equivalent electrophysiological test. But does it mean that we replace all behavioral tests? No, it doesn't. But behavioral and electrophysiological always go hand in hand. We have, for whatever purpose that we have, these are the purposes, and we have equivalent APs to be used for all these purposes. Generally, even when in class, it's a little easy to go according to these criteria. That is that AP, like if you want to critically evaluate an AP or understand its utility, I generally put it under these categories. Threshold estimation. Is it helping you understand the type, degree and configuration of hearing loss? Is it able to help you differentially diagnose or identify the site of lesion? What role does it have? How efficient is it in assessing auditory processing? Then we have candidacy for rehabilitation, which is very similar actually to threshold estimation, but candidacy for rehabilitation will also include a few other things, so I have kept that a little separate. Aditi will talk about it. Aditi and Kulse will talk about it later. Then, very importantly, later AAPs can be used to assess benefit from hearing devices and monitor neuroplasticity related changes, like effect of the amplification, effect of development, effect of training, effect of a rehabilitation measure, all these things. So AAPs, it is important to choose the right AAP. These are the different APs that we are going to talk about today. I will not go into detail because it's going to be explained further. And these are the contents of our presentation today. For newborn hearing screening and the role of APs in newborn hearing screening, we have Ms. Shruti SG, diagnosis of auditory disorders by Ms. Kutsia Khan, evaluation of auditory processing will be spoken about by Riaz, and auditory potentials for rehabilitation. We have two parts. One is EABR and CAPs, which will be done by Ms. Aditi Oswal and me respectively. So I will hand over now to Shruti ma'am to continue with the presentation.
Good afternoon, everyone. I think after a long presentation of heavy topic of auditory AEP, maturation and everything, now we are moving on to a lighter topic, but then yet very important topic. So I think I got a very beautiful topic, but on a challenging hour of the clock, which is like ideal climate for you to sleep, nice 24 degree AC and after food. I hope nobody sleeps, okay? But I am really excited to stand here, especially because I am standing in front of a very unique crowd, which you will not get it in any corner of the world. I can see the teachers who taught me. I can see my students whom I have taught. I can see my seniors. I can see my juniors. I can see all my classmates. I can see all the new students of BVP. So it's like a very unique crowd. So I'm very excited to present this particular topic. So I hope you all stay awake. So newborn hearing screening in India. So as students, many of us, I think all the students in BVP since quite long years, everybody would have done hearing screening, right? It's like a routine part of our clinical posting. We all have been doing that. So I would like to ask you a question. As a professionals, once you passed out from the college, how many of us are actually into newborn hearing screening? Can you please raise your hand? Students, put down the hands. I am asking for professionals. Students, I am sure that you are all going for hearing screening, right? Okay. So I can see only hardly few hands in the professionals. Among the professionals, I can see only few hands. So this is what we are going to do in this presentation. We are going to do a reality check as to what exactly are we doing in newborn hearing screening, how are we using the AEPs in this, what we can actually do and what we are
be doing. Okay? So this is one of my favorite topic for the reason that there is a lacuna of work, a lot of lacuna of work where as an audiologist we should come together and work towards it. So not from a research point of view but from a practical implementation point of view. So along with that, the one more personal reason is that this particular topic is in alignment with my PhD topic of I have done my PhD, my thesis topic is in ABR in preterm and term infants. So due to all these factors, I personally would like to do a lot of work when I step in after my PhD. I would like to create some impact. So what I expect from this presentation is not you take down the notes, you get some theoretical knowledge, no. For that, upcoming so many presentations are there where they will give you a lot of compact information. This presentation is for you to open your eyes. Okay? So what's the clinical? Our title is Cradle to Classroom Continuum. So here we have our Sophie, which is generated by AI. Okay? So I would like to ask you that we have seen so many. This is like a representation of our newborn hearing screening. So baby Sophie was diagnosed with hearing loss and then later on toddlerhood and then has become young student. So like this lot of Sophies we have met during our clinical practice. You would have done a lot of hearing screening where on the register you would have seen rubber. So I'm sure that you wouldn't have seen Sophie, where Sophie is as a toddler, what she is doing as a young student, is she even wearing the hearing aid, is she shifted to cochlear implant, is the child even started with, like whether the child was actually sent for diagnosis. We are lacking with all this information, right? Do you agree with me? Okay. So during this particular continuum of cradle to classroom, our role as audiologists in using AEP does not stop at neonatal hearing screening. It continues till efficient use of it. It has to continue, a lot of work has to continue throughout the developing ages of the child. So I'm not going through each slide by slide and reading it out. I'm only filling the content of it. Okay, so all of you know that what is the need of screening, right? Basically, we are doing all these things to stop prevention of permanent disability to the child. Whether it can be like at every stage, the consequence of hearing loss is different. So an undetected hearing loss has impact on delayed babbling, poor vocabulary, speech and language deficits, thereby academic difficulty, and so there and both on the child is going to have trouble. So our whole aim of early detection and intervention program, you all students have heard, right? And professionals are trying hard to reach this particular early detection and intervention program. Now we have these numbers, JCH program, all students have heard, right? So you have seen that 136 and 123. So 136 is the global benchmark which is currently followed, even though 123 is suggested by JCH. So it's not a mandatory protocol to be followed for 123. What is the global benchmark currently followed is 136. However, we are supposed to scale up our work in such a way that we reach till 123 for the reasons that premature babies also do come into the picture of, you know, premature babies, right? Ma'am was telling, I think Rucha ma'am was telling about babies born before the term getting completed 37. So if they are born too early, how will you actually complete it? So for those reasons, our aspirational goal is 1, 2, 3. If you target 1, 2, 3, it's like if you target the star, you will land on the moon, something like that. So when you target 1, 2, 3, finally we 1, 2, 3, we finally reach at least 1, 3, 6. So hopefully you understood what is 1, 3, 6. I am just explaining. 1 is for screening and 3 is for diagnosis and 6 is for intervention. Same like that for 1, 2, 3 for others. So by 3 months you have to fit the cochlear implant or the hearing aid and start the intervention. So that goal is too far for India to achieve at this point of time. At the same time, we are not in too infancy. Many of the states in India are doing good in achieving 136 as well, scattered, that we will come to know. Okay, so here you can see the newborn hearing screening, diagnosis and monitoring loop suggested by JCI's 2019. So in this particular diagram, we are actually stuck somewhere. What we as an audiologist is doing in every setup is, we reach till the child is pass or refer, and somewhere there our role is ending and we think that it is somebody else's duty to do the rest of the things. In fact, we need support from probably government, that is true, but then we are getting stuck somewhere in this thing that okay, once the baby is passed, it is getting over, or when the baby is refer, you do not know whether most of the condition there is a loss to follow-up ratio, where after refer, the follow-up is dropped significantly due to few reasons which we will be discussing it again. And after that, this is the newest thing which they have included, monitoring loop. Whether they pass or refer, you have to monitor the child throughout their infancy, throughout the continuum of their, that is cradle to school age and beyond, to make sure that progressive hearing loss, late onset hearing loss, this type of things does not happen. So we have not reached here at all because we are stuck already there. So our aim is to reach here in the monitoring loop, which takes a lot of, we need a lot of technological advancement, adaptation, we need a digital tracking system. So we'll be further talking about that. Okay, so now we have currently in newborn hearing screening, we have a two-stage newborn hearing screening protocols which we all know. OE, you check whether it is pass or refer. Which OE do we use, by the way? I'm not going too much basic, which OE, why DPOE, why TOE. I hope all these things are basic for everybody, so we are not covering. But still, which OE do we use? TOE, right? Ideally speaking, we should be using TOE. Some conditions, some places, they do use DPOE due to noisy situation. So ideally, OE, pass or refer, and then if it is refer, AABR is used for. AABR is used, and AABR will be further, if it is pass or refer, based on that, diagnostic ABR will be done. So how many of you are using AABR? Have you all used it? Okay, I would like to know how many professionals are using AABR in their clinical setting. Anybody? AABR? What is AABR? Automated ABR. So now in this particular presentation, we are going to focus on AABR, how exactly it is useful, why, even though it has higher cost involved, we should still be doing, and why we should be doing it. Okay. So basically, AEP, if I tell AEP is the backbone of pediatric audiology, which I would like to believe like that. Even though we have behavioral things to support, AEP has changed the game of pediatric audiology, isn't it? Right? So AEP has changed the game overall, that how pediatric audiology has turned around. Similarly, without AEP, scaling the newborn hearing screening program in the right direction is difficult. So if a state or a country has to achieve a good level of audiology setup or audiology professional scaling has to happen, it has to start with an efficient newborn hearing screening program, including use of an AEP in that. Okay, so currently screening program, as I told you, it is two-stage program. Every particular setup is using different protocol. So this combined approach, why are we using it? It is to improve the detection of cochlear and neural hearing loss components. So our Vanaja ma'am and her student have done a beautiful study of audiologist perspective in of newborn hearing screening. So in that they have also mentioned that identification of disorders such as ANST is being missed in India as AABR is not used in many programs. So in India, we don't have a standardized protocol that everybody uses the similar protocol for due to several reasons. Okay, now if you see, when we use clinical, when we see clinical role of AABR, as I told you, it is for neural evaluation and to detect auditory neuropathy disorder. Have you anybody seen ANST cases? Right? You all have seen. So it becomes the tricky part that unless we do a AEP, you don't come to know that there is a problem. By the time you come to know, it becomes very late for any intervention to happen, because you will come to know only when the child starts going to school probably, or when the child has to start speaking. The language does not get developed properly. So that's too late. Like around 2 years is too late. So if you compare OE with AABR, so up till now, even though AABR was there in the international standards, till now we have not been in detail using AABR for newborn hearing screening. Who was the hero? Hero was OE, right? Now also in many places, hero is considered as OE. But then is OE doing a justice for overall newborn hearing screening? If there is nothing else, then OE is the hero. But it has to be combined with the right heroine, right? AABR has to be there along with the OE. Then only it makes the things complete. So if you see OE and AABR, so basically the source, primary source of this thing is outer hair cell, and the other one is auditory nerve and brainstem. So if you see ANST detection, so you get in OAE a false pass that they don't say that there is a hearing loss, they pass the test telling that it is good to go, right? So here in AABR, when you do, you get a reliable refer which detects ANST. Now consumable wise, if you see, OE has low maintenance, low cost involved compared to AABR, where initial cost also is high and also maintenance cost is also high of 300 to 500 electrodes per electrode. Subject, again, relatively, we both need a quiet baby, and one need, if you have a natural sleep, it will be better. So if you see the efficiency of both OE and ABR, you can see the diagram, put the same thing there. Okay, so you can see how specificity and sensitivity is more for AABR. That means that in AABR, there is significantly, it reduces the chances for false positive, which is caused by regular transient rates of middle fluids, which is common fact for first few days of the screening. That is why we say that, okay, it is rougher as of now, you come back after, before discharge. This is what we say in hearing screening, right? OE sometimes come rougher, and we say that you come back after some time. So this particular scenario, the chances are only less than 1% for AABR. So now let's say what are the advantages and limitations of AABR? It detects the, as we discussed, neural component. What is the limitation? It detects, but then it is costlier. Towards the end of presentation, you will understand that cost. Does it actually justify spending that much? So lower false positive than OA, but it needs longer time to get completed. That calculation also I'll show you how much longer. Is it worth doing that much longer? Automated pass or refer, that is like diagnostic ABR, you don't need to really rely on your judgment of whether peaks are present or not. It is being automatically calculated, and just like OE, it do come. So it need but consumables like electrode, which cost, and it is sensitive to movement and noise. That is also another problem. But compared to OE, it is still possible in slightly noisy situations. Ideal for NICU high-risk infants, and it has high specificity. Okay, but it is not frequency specific, and also it requires a little bit trained professional than OE. OE, you just need little bit training. ABR little extra understanding of electrode placement and cleaning. That's all. this particular diagram shows that what are categories of children do we get when you screen. You get preterm babies, NICU babies who are not preterm but high risk. You get, among that, when you do screening, you get to know that there are children who are normal hearing, there are children who are having damage to sensory issues, that is cochlear hair cell damage is there due to some high risk, or they might have ANST related issues, which is neural pathway dysfunction, and this can be figured out only using the combination of AABR with that of OA. Okay, so now we'll move on to a auditory maturation delay. So in this, one more thing is there. So in permanent damage, there is neural damage, there is sensory damage. There is something called as transient damage, that is transient problem, that in the test it do shows a problem, but then is it a permanent problem? No, until if you don't treat it correctly or if you don't address it properly, then it might lead to problems. But then there is a transient maturation delay which is usually associated with preterm babies or NICU high risk babies. So we'll talk about that. So there is how much impact of this particular thing is auditory maturation delay. What is auditory maturation delay? So basically, as Rucha ma'am was telling, the maturation happens, right? So in that maturation, the auditory pathway is getting mature even after birth, right? They can hear completely, but then auditory neural pathway is getting mature. So birth to 3 months, 6 months, and so there is a plateau of neural maturation which is happening. So those children who are born before time will have an issue of maturation which will be getting reflected just like ANSD in AABR. Okay? So auditory maturation delay, I have 10 more minutes, 5 more minutes, right? Was that well for me? Yes. So auditory maturation delay versus ANSD. Pay attention, this is the core part of this thing, this presentation, that OE result when you do an auditory maturation delay patient versus ANSD, what will you get in OE? You get a typical past response, that you will counsel the patient that if you stop your screening at that point of time, you will counsel telling that, go, everything is fine. Is everything fine? No, it is not fine. So if you do AABR, then you will get again failed response in both for ANSD as well as auditory maturation delay. Why in auditory maturation delay you get failed response? Because AABR is an automated response based on weighted average template matching, where the maturation is not so great that it will match to a normal template. So they reject and say that it is rougher, or the wave 5 is little bit late than the timeline which is fixed in the AABR instrument. So it is not, the child is not hearing. Child is hearing, just that the instrument is not able to detect that particular response. So what you have to do is, you have to do a diagnostic ABR in this case, where you can assess the interpeak latencies, cochlear microphonics, and further understanding the morphology of the particular patient ABR. Okay. So prolonged interpeak interval will be there for 1 to 5 interval. It will be slow conduction for auditory neuropathy, auditory maturation delay. In auditory neuropathy, what will happen? Either it is so bad that you cannot detect a peak at all, or it is completely absent. Okay. When you do a diagnostic ABR, you can also focus on cochlear microphonics, where there is normal duration for your auditory maturation delay, and for ANSD you have long ringing cochlear microphonics. So basically ANSD does not pick up with the time. There are few ANSD which do pick up, but then it's not called as ANSD. However, for auditory maturation delay, it usually normalizes by 6 to 12 months. So what is important is your continuous monitoring. So when you do AABR, around 10 to 15% of rougher babies are actually auditory maturation delay and not actual ANSD patients or actual sensory cases. So what is the current status in regarding newborn hearing screening and AAP use. High income countries, they have a screening coverage of 95 to 99%. Okay, but still they also have obstacles in completing this. It's not like they have moved on completely to 123 protocol. They are still in 136 protocol. Middle income countries like India, we have 40 to 80% coverage, ranging from rural to urban. Okay, so the main obstacle is rural access and electrode cost. If we have to do AABR, low income countries still have less than 10%. So at a global level, universal newborn hearing screening is not yet universal in nature. Okay, it is country wise, they are trying. So now state-wise distribution and implementation, if you consider in India, we have Kerala and Tamil Nadu and Goa state district have one of the most good coverage of newborn hearing screening. So as you can see, in Maharashtra, risk-based screening is still happening at other than academic institutes and other than public health systems. The regular screening is not yet happening. So if you consider Pune, Bangalore, these type of places, 90%, supposed to be 90% or more than that is using AEP. But rest of the rural areas, other than Pune, Bombay and rest of the places, they are still depending upon only on OAE for screening. So if you use only OAE for screening, what will happen? You will miss ANST. So in Indian model, typically OAE followed by AFBR and followed by diagnostic is the protocol. So according to international guidelines, as we have discussed, how it should be for well baby and NICU. In NICU babies, they only use AABR, only, strictly. So a similar model is followed by Kerala state. So they have, a decade ago, they have already established their newborn hearing screening program with the digital tracking system that they are able to do that monitoring of loop system. Approximately a decade or 9 to 10 years ago itself, they have started doing it very efficiently. But at other places, as per Indian national guidelines, OE and AABR is combinedly used. Okay, and also in India it is more of opportunistic. That is means if the child is not done at the first discharge, then let us do it in the next stage of next stage of immunization. So it's like opportunity. We do it whenever the opportunity comes, which should not be the case. Okay, so I think I need more time. Okay, so why we are not able to implement this AEP at a larger scale is policy differences. We want the government to cooperate. We want good infrastructure. Again, infrastructure should come with the money, right? Workforce is limited. In India, one audiologist is serving 5 lakh population. In economically stable countries, it is 1:50,000 ratio. So that's a huge ratio for one person to do it. So technical difficulties of implementation is in rural areas. Mothers migration, that is after getting delivered, they move to one city to another. We are not able to track the patient, not even first follow-up of OE done first. Before discharge itself, they get voluntary discharge and go. All these things are typical Indian scenario. If we have to track this, what we need is this loss to follow-up ratio. Can you see how the graph is decreasing? So all these things if we have to do, what we need is a digital infrastructure which has to be in coordination with the government. So ABHA and RBSK are two programs which are going to be in your future, going to be the future of newborn hearing screening. That basically it is a number for every newborn child. Okay, so that number will be attached to a digital portal where anytime you put the number, you know that okay, OE is done in this particular center, but this child has not followed and done the ABR. And if ABR is done, whether the result is pass or refer. Now you can only understand about your institute, nothing baby shift from one place to another, can you come to know? You cannot. But then with this particular new protocols which is going to be implemented in India, we will be able to track the whole country's newborn hearing screening under one particular roof. So as I told you, AABR can be done very easily within 15 minutes. This is the distribution, and ASHA workers or grassroots level workers can be trained for doing this. 15 minutes of work. So what's the future perspective of newborn hearing screening? So basically, universal access of OE and ABR for every hospital birth, just now how I explained you. We have to target 136 benchmark across the nation, and digital backbone, that is you have to use the tele-audiometry cloud-based system and support from government to start with digital tracking system, and public and private partnership also has to be done. So basically in future AEB, when I say AABR is not limited, it is only the starting. So as I told you in JCH, it is a long continuum. It is not just the screening process. It is after screening what happens, diagnosis, after diagnosis what happens, intervention. In all these places, AEB is going to form a strong basis. So in this AABR, chirp stimulus is used, which are one of the Kutsia will be discussing further on that. Those things you can hear from the technical details, how exactly the protocol is there. So basically, is it possible in India that you do a universal newborn hearing screening? Yes, it is possible if you use AAB and digital tracking system with the incorporation of newer technology, and we can scale up this process. Okay. So do you think that we will be able to make a difference as an audiologist? Would you like to do any work on this? Do you see there is a problem? Yes, do you see that, right? So as a professionals, we have to use the technological advancements in making newborn hearing screening a success in India. So why I say future possibilities are infinite? Because I feel very blessed to be in this era where we have seen non-digital to digital, and we can even see AI. Now you can see I have generated a lot of images using AI, so I have given credits down there. So basically, even AI-based AEB interpretations are going to be the future of audiology. So all these things, previously even if I would have decided I will scale up the newborn hearing screening with paperwork, was it possible? It would have been a hell of a work. It's not that possible. Like how Kerala State have tapped the correct advancement at the correct time, we can also do as a overall India. There is a movement going on, so we all should be part of this movement and take this to next level. Then only there is a future of audiology in India is still there. Every newborn has to be screened, right? Then only we will get patients. Future patients. Okay. Thank you so much for your patient listening. And hand over to Kutsia.
Good everyone, or should I say good morning? I'll try to be a bit more interactive. I'm going to ask questions. So I'm hoping that I'll get answers, and I hope that people aren't really sleeping, hopefully. Or I don't put you all to sleep, right? At the offset, I'd like to thank the institution for having given me this opportunity and to think that I'm still worthy of doing this. So thank you. Before I begin though, one ring and 20 minutes, is that it? Okay, so I'd like to stick to that. Thank you very much. Okay, so yeah, my name is Kutsia Khan, and I am trying to focus on the clinical applications of auditory evoked potentials in identifying auditory disorders in the pediatric population, right? Which essentially would mean that we are going to focus on threshold estimation using AEPs, and then also in diagnosing disorders that we commonly see in children. I'm not going to focus on the ones we see in adults primarily because that is not our where our talk is focused today. We're focusing on children and pediatric population. So I'll only be focusing on mainly those disorders that we commonly encounter in clinics when we're dealing with children, right? But before I progress, I'd like to ask a very basic question to all of you guys here, is if the crowd, whether right or wrong, can tell me what are the causes for conductive hearing loss in children versus what are the causes for SNHL. You may be wrong, it's okay, I need to know where you are and take you from there. So, conductive hearing loss. Somebody louder. Otitis media, lovely. What else? Atresia, super. What else? Super. Foreign body in the ear. Anything else? Microtia, anotia, stenosis, things like that. Right? Congenital malformations that we are born with. Okay, versus SNHL. Syndromic. Good. Anything else? In the anomalies. Okay, good. Anything else? Congenital hearing loss. Whether syndromic or non-syndromic can be genetic also. Yes, true. So these are some of the common reasons why you will see a conductive or a sensory neural hearing loss in the pediatric population. Correct? Okay. I'm asked you this question for a specific purpose. When we proceed, you realize why this question was asked. But right now, beginning the talk, auditory evoked potentials basically represent the electrical impulses generated across the auditory system from the cochlea. That's the most peripheral, most generator per se side, going up to the cortex. And what we as radiologists do is we are trying to pick up or map these electrical impulses along the system and try to make a roadmap of how we understand where exactly the problem is lying so that we can intervene accordingly. Correct? So, what is very necessary, like Rucha ma'am also said in the beginning, is we just can't rely on auditory evoked potentials. We do need to back it up with another audiological test, preferably behavioral test, and that is something that the cross-check principle tells us. It's established way in advance that we need to back up every AEP or every electrophysiological test with a behavioral test as well, right? So we have various causes, but it's very necessary that we know hearing thresholds specifically so that we can do necessary habilitation or rehabilitation for the children, right? So there are different electrophysiological tests that we have. Can we name some on the outside? What are the tests that we know? We've spoken about it for quite some time now. Just off the bat, whatever you think are electrophysiological tests. Yeah, I feel I need to do my listening in noise test or something, right? Because I couldn't understand what people said. But I heard ABR and LLR and MLR, so that's good. At least you're paying some attention. You weren't sleeping the entire time. But yeah, so very quickly I'll focus on auditory brainstem responses. I'm not going to go into the basics of the details because that's something we know. If at all a question, we can take it at the end of the session, right? So it's an early latency response that occurs within the first 15 milliseconds of when the signal is given, and it represents the synchronous firing or the synchronous discharges of the auditory nerve fibers. Correct? It's a far field recording. Far field recording would mean that the generator sites are the cochlea and the auditory brainstem, but we are not picking up the potentials or the impulses from the site itself. We are placing electrodes much far from the generator sites and we are trying to pick up those responses, right? So it's a far field recording, and usually commonly used in clinics, I think even today, is clicks because they are quick, they give good responses in terms of amplitude and wave identification, and also they give you information about hearing, but in a broadband sense, in the sense that clicks are broadband stimuli which are going to give you information. Some authors say between 1000 to 4000 hertz, some authors say between 2000 to 4000 hertz, right? But that is the frequency range in which clicks will going to give you information about your hearing. Okay, so these are the most commonly used ones, and there are various studies done about it. There are studies done saying that, like Heidelberg in 1990, said that there are 1367 years of infants were tested and then eventually backed up with PT, and they found that ABR thresholds that were found in infancy had a sensitivity of 98%. Right? Likewise, another study done in 2013 showed that there's a high positive correlation between the PT and the ABR thresholds in children that we see. But like I previously mentioned, clicks don't give you frequency-specific responses. If I were to ask you, you've done a click ABR, what is the threshold at 2000 Hz or at 4000 Hz? I don't think you or I would be able to pinpointedly tell, oh, this is the threshold. Oh, the child hears at 50 dB and 50 dB HL at 1000 Hz or at 4000 Hz, right? Because it's a broadband stimulus. So there's a very necessary or need of the hour is we need to identify masking technique and noise methods. But the problem with all of these techniques was that whenever they gave the stimulus along with the noise, the masker and the stimulus were interacting. So there was obscurity in visualizing the wave 5. Identifying wave 5 or ABR waves was very difficult, right? So eventually we moved to something that's more routinely used, I would say, and that's called the tone burst stimulus. The tone burst stimulus is nothing but clicks cut down into frequencies, right? One broadband click stimulus chopped down into different sections, each section centered around different frequencies. So 500 Hz, 1000 Hz to 4000 Hz, right? But again, tone burst APR has multiple disadvantages as well. For one, wave morphology at low frequency, when you use low frequency TVs or at 500 Hz especially, we see that the morphology of the response that you attain is very poor, right? And the latency is in the 9 to 12 millisecond bracket. The same latency window where you will have obscurity in visualizing the waves because of the presence of a post-auricular muscle artifact, right? So sometimes you will not identify whether it's a wave or it's a PAM artifact simply because they lie in the same latency period. The other thing is that the difference between TVAVR threshold and the behavioral threshold is anywhere at low frequencies, anywhere between 25 to 30 dB. So by the time you actually reach maximum transducer output limits, if you're trying to test say at 90 or 80 dB initial using TVAVR, you're probably only going to be able to diagnose moderate to moderately severe hearing loss. If at all you have hearing loss that is more severe in nature, you will not be able to identify it simply because TVAVR has maximum limits with which it can test. So, because of all of these disadvantages, we have something called as the chirp stimulus which was developed, and that is trying to compensate for all the disadvantages or the drawbacks that the clicks or tone bursts have come up with. Basically, what they do in a chirp stimulus is, in a broadband chirp stimulus, they will. Okay, before I go there, can somebody tell me, or all of you are telling me, what is the tonodopacity of cochlea? In the sense that where are high frequencies generators in the cochlea and where is the low frequency? Base has high frequency, correct. So now when I'm giving a broadband stimulus, what happens? If I give a broadband stimulus, the high frequency region of the stimulus reaches the base first. By the time the low frequency region reaches the apex, there is a lot of upward spread of energy. So now what is happening? The base region of the cochlea responds first. By the time the low frequency region reaches the apex and it responds later, there is not exactly a synchronous discharge. The base is responding first, the apex responds later. What they have done in chirps is they have reversed the entire system. They are giving the low frequency part of the stimulus first and the high frequency later, so that by the time the low frequency reaches the apex, the high frequency is given, so the entire basilar membrane shoots at one time, so you have a more robust response. Make sense? Okay, good. So, again, chirps initially were developed on the traveling wave model that I just explained, but they realized that when testing with chirps, there was a drawback that they were facing, and that was that after 80 dB HL, there was a sudden drop in the amplitude and the morphology of the response they were receiving, simply because there was upward spread of excitation, in the sense that beyond that point, energy was too haggard or haphazard for them to get a synchronous discharge, right? So what they did is they realized that if this is, intensity is the game changer here, what they did is they changed the chirp based on intensity. Okay, so now they have made chirps that are dependent on intensity also. What they basically did is they have temporarily aligned the responses that you get through chirp APRs for all intensities on paper. When you do it in practical, of course there's a slight delay, but the entire purpose of that was to eliminate that drop in the amplitude and the obscurity of the wave that they were facing at 80 dB HL, right? So now it's dependent on the intensity also, and when this is dependent on intensity, they decided to call it level specific chirp. So far so good? Half of them are sleeping. So far so good? Yes. Good. Okay. So, right. also with level independent chirps, right? And they found that the maximum amplitude was attained using LS chirp at all intensities. So that was one major hit, because now you are able to identify thresholds, you are able to identify your ABR waves with significant ease. Okay, right. The other thing that they found was when they compared chirp ABR with tone beat ABRs in children aged 6 to 12 months, they found that the difference between behavioral threshold and level-specific chirp ABR threshold was only 5 dB. So if I am testing a child and I got level-specific chirp ABR threshold at 2000 Hz at 60 dB NHL, probably very high chances that the behavioral threshold would be 55. So that way, now if I am testing at 90 dB NHL, I can sufficiently say the threshold is 85, the child will have severe hearing loss. So now you can also very easily label or test children up to severe hearing loss, as even profound for that matter. Right? Okay. This was a study done by myself and Manju ma'am, but there is a catch. This was not in children. This was in adults. The only reason why I displayed is for you to be able to appreciate the difference in morphology between burst ABR and level-specific chirp ABR thresholds. So on your left are your TB ABR threshold PX, and on the right is level-specific at 500 Hz, and you can see up to 20 dB NHL. I can very easily and very clearly identify the peaks, right? I can close my eyes and say that that's a wave 5. As opposed to in TB-ABR. Even the latency period for TB-ABR is significantly delayed, correct? Not delayed, but yeah, it's in a later time window as opposed to chirps. Okay, similarly for 1000 Hz, 2000 Hz, again tone bursts on your left, level specific chirps on your right, and 4000 Hz. Okay? Right. So, another newer addition to identifying responses in AEPs is something called as FMP analysis, which is nothing but they are doing a F ratio. They are checking the variance. When you test a waveform, they are checking the variance in the noise level in that waveform at multiple points. That's what MP stands for, right? So if I'm taking, say, FSP is when you are testing a single point in that entire waveform, versus FMP is when you are testing multiple points in that entire waveform, right? If I take 1000 runs with FSP, I'm selecting one point. Say for example, at 60 dB NHL, I want to check presence of wave 5, so I'm going to test between 6 to 7 milliseconds, and that's one point that I've selected. I will need at least 700 runs before I can realize that this is the waveform or this is the wave, and that's a response, because I'm testing just one point, right? In FMP, what you're doing is you're selecting multiple points across the waveform, and then you're testing for noise and presence of response, right? So now, for what I needed 750 runs, I can only do in 250 runs, because you're testing multiple points to have more averages, and then the ease in identifying the response becomes much higher, becomes much easier for you to do that, right? Okay. Reason why I was talking about BCABR and I asked conductive hearing loss is because somewhere or the other we need to identify the importance of doing BCABR in children because of the congenital outer and middle ear malformations that they may be born with, only to be able to identify if it's a mixed loss or a conductive hearing loss, and accordingly decide our intervention. Okay, so if you're doing BCABR, this is the usual stimulus and response measurement parameters that we use for BCABR, but there are drawbacks. Again, one is when you placing the BC vibrator on the skull, depending on the thickness of the skull, the age of the child, the amount of stimulation that is actually reaching the cochlea cannot be decided, not be ascertained. So two children of same age and all things similar will not have a similar amount of stimulus intensity reaching their cochlea simply because of the variations in their skull thickness. Okay. The other drawback that we face is that because of bone conduction, bone BC vibrators that we use, there's a stimulus artifact that makes it difficult for you to identify at least the first few milliseconds of your waveform, right? So because of that, because of these two reasons, BCABR is not very routinely used. However, we should still use it simply to be able to differentially diagnose conductive versus mixed hearing loss. Okay. Now, another problem that we encounter in children is having neuropathy, ANSD, spectrum neuropathy, dysynchrony, sorry, my bad. Okay, in ABR, what we routinely very commonly see is that we will have absent responses on ABR simply because dysynchrony has can have a presynaptic, a synaptic, or a postsynaptic problem. Correct? Right? Either way, because of the site of fusion, whatever stimulus you are giving is not causing synchronous discharge of the auditory nerve fibers, which is essential for you to get an ABR. That's the basic. Right? But because of dysynchrony, you are unable to do that, which is why you will never find an ABR in children with ANSD. However, what you will find are cochlear microphonics, right? And how do you identify them? Usually at high intensities, you can sometimes have waveforms that have ringing in front before the actual waveform can be identified. To be able to differentiate whether it's a cochlear microphonic or an artifact, what you do is you test at two polarities, right? Rarefaction and condensation. When you change the polarity of the stimulus, the polarity of the waveform or that cochlear microphonic will also reverse. Right, and when you average it, when you add the two polarity waveforms, it will get cancelled out and it will be a flat line. Of course, ideally, but it will get cancelled out, so you know it's a cochlear microphonic. Two ways. Okay? Right, moving on. The other electrophysiological test, oh, seriously? 20 minutes? Oh, very nice. I'm very done. 5 minutes more? Can you have any minutes more? Thank you so much. We have electrocochleography. I will not get into the details for obvious reasons. We check cochlear microphonics, summative potential and action potential. Of course, I'll just tell you the generators. Summative potentials are generated from the inner hair cells, and action potential, the first wave of area, is generated from the auditory nerve fibers, whereas the cochlear microphonics are from the outer hair cells and housed within the cochlea. These are the different kind of electrodes that we use to measure ecology. And the difference in ECOG response when you use a TM electrode versus when you use a tip electrode, the SP or the summative potential is more enhanced with the electrode that is closer to the site of generation. Again, I've explained this before. Alternating polarity will cancel out two different polarities and you identify the schemes better. Right. Yeah. Done. Right. So, in ecology, if you have an abnormal summative potential while your cochlear microphonics is present, like I said, because the generation site is in the inner hair cells, we can identify that the ANSD is most likely because of an inner hair cell problem, right? But if you have a problem in the synapse or if you have a problem in the auditory nerve, that you will not be able to identify because the distinction, because there is no such test per se yet that can identify a hidden hearing loss or a synaptopathy, right? So yeah, you will have an absent ecology in these cases. Okay, ASSR, again, you have bottom line, all authors saying that ASSR results are very variable with questionable association with other ABR or electrophysiological tests because of how unreliable they are, right, with poor reliability. So they always say you use ASSR for its advantages in the sense that you can test high intensity and identify thresholds at very severe or profound hearing losses, but also in conjunction with other electrophysiological tests. Right, and this is a very good study wherein they tracked cochlear microphonic threshold in ecology and compared it to ASSR threshold to see whether there is an absence or presence of ANSD. Right, and they said that it's a useful additional diagnostic tool because it correlates with the cochlear microphonics you find in ecology. Again. LLR, it's an endogenous potential, that is, the responses will change depending on whether you're paying active or passive attention, and it gets easily affected by drugs and sedatives, and you may see a dip in the amplitude and a delay in the response latencies. Of course, Chan's covered this, age maturation. I just got 2 case studies and then we are done. Okay, these case studies basically focus on children with ANSD, right? We had both of these studies were done at Bharati mix up here. Thank you for that. What we did is we did an audiogram and we found that the right ear has moderately severe SNHL while the left ear has moderate SNHL. And when we did speech audiometry for phonetically balanced word list, the WRS, so the word recognition scores was 0. So that was like a big hit. Oh, probably there is a problem, right? Because for this kind of hearing loss, it shouldn't have been 0. The other thing is when they did it for just numbers, when they did WRS for numbers, they found 16% for the WRS scores. So what they did was they went ahead with an ECOG and they found that there was query submitting potential seen on in both the ways. So they thought it's probably a synaptic or a post-synaptic problem, right? Because pre-synaptic problems, if it were a pre-synaptic problem, the inner hemisphere would be affected and you won't see a submitting potential in that case, right? So then they did an LLR, both unaided and aided. What they found was they did see P1 N1 responses in 1 year, in aided and unaided condition both, whereas only in aided condition in the other year, and because of that, now cortical potentials don't really require synchronous discharges. Depending on how severe your dyssynchrony is, the presence or absence of the response will vary, right? Because we saw responses at in cortical potentials, it was moderate dyssynchrony. Because you had other ABR was absent and you had poor WRS scores, coupled with the fact that this LLR was noted, we will term it as moderate dyssynchrony. Okay. The other case where we had moderate SNHL in the right ear, class case, and moderate rising type in the left ear SNHL with poor WRS scores. We went ahead and did ABR. We found that ABRs were absent, but like again you see here, there are cochlear microphonics present, but these microphonics are only seen when we use chirps and not when we use clicks. Okay. When they did ECOG, again cochlear microphonics seen on both sides, if you can appreciate it on the top there, yeah, and maybe here, maybe you see cochlear microphonics. So we know that it's a synaptic or postsynaptic lesion, and LLR here was absent, as opposed to the previous case where LLR responses were seen. Here LLR responses were absent, so we labeled it as having severe dyssynchrony. Okay? Right, so in conclusion, couple your evoked potentials with behavioral tests and multiple reasons why we use AEBs. I focus on the diagnosis and the threshold estimation. My colleagues here will focus on the rest. Yeah, these are my references. Thank you.
Please note down the questions that you have. We are a little short of time because we are running late, but we will take up questions at the end of the session together. So if there are any questions, please note them down. We'd love to discuss.
Hello everyone. Before starting the presentation, I would like to thank my college for providing me with the opportunity where I could come here and speak to you. Now, my topic is mostly about use of AEBs in diagnosing or assessing central auditory processing disorders. Usually in our clinics, we use behavioral tests and not more of electrophysiological tests to assess CAPD. But there are many articles which will highlight the importance of use of electrophysiological tests to assess various processes. So, introduction to CAPDs. Usually, according to American Association of Audiology and ASHA, they say that if there's any problem, any functional problem in pathway from our auditory nerve to the brain, then if that problem is detected through behavioral tests and not detected on hearing test, we call it as CAPD. Also, there are various processes which are involved. So there are two basic approaches to assess them, that is the behavioral test and the electrophysiological test. Now, what are the various processes which are involved? So there are processes like binaural integration, binaural suppression, temporal processing, auditory closure and memory. Here in this table we can see the behavioral measures and equivalent electrophysiological measures to help us identify if there are any problems in this particular processes. I have also mentioned neural generators for the same, where are the waveforms or what are the areas where we get the waveforms or are responsible for that particular process. We'll start with binaural interaction component. So binaural interaction component is usually found in ABRs, MLRs, LLRs. Now here we have to be very careful about how we use a particular test. So we can definitely modify our stimulus and recording parameters to assess a particular process which we want to assess. So supposingly if we want to assess binaural interaction, we can use ABRs, MLRs, LLRs, we can use every potential. And what it usually means is, so here what I do is I record a waveform from left ear and right ear and sum it up. Now there's a binaural ABR done and we subtract the sum wala ABR with the binaural ABR. And we get a waveform. This waveform, the DN1 which we can see, is the binaural interaction component for ABR. So studies have found that if the binaural interaction component is present, we tell that the binaural interaction is intact. We'll see the same through various studies. The first study done by Delp et al. In 2003, he tried to measure or evaluate BIC in children diagnosed with CAPD using ABR. He compared binaural responses and sound responses and he subtracted it. He told that it was useful, the BIC was useful in identifying CAPD and reduces influence of attention-related confounds. So, if we use LLR or higher potential, the attention part becomes a confounding variable for us, and those potentials, as they are late, so maturation of that process also becomes late. For an early intervention or early diagnosis, BIC ABR can be used. Second study done by Brattenberg et al. In 1999, he recorded ABRs in normal hearing children, used objective detection methods and instructed BIC. He demonstrated that reliable measures of BIC and validated objective detection techniques. So this was very earlier study done in 1999. Third study, which was the recent one in 2015. They used the stimulus, which is a speech-evoked ABR, and they measured BIC peaks. This study, as we know, speech ABRs or usually SFRs have multiple peaks, which are generated from throughout the brainstem. And in his study, he found multiple peaks. So DN1 is the fifth peak. He observed peaks after that also, and BIC was observed. So peaks were observed at 6, 8, 36 and 46 milliseconds. Similar thing, BIC and MLR. Now, BIC and MLR is most used because MLR के waveforms are little larger in amplitude, so it becomes easy to assess. First study done by Abdullah et al. In 2017. He did MLR in 60 children and 60 CAPD children and compared them. So he found significant differences in latency and amplitude, MLR, BIC in CAPD in children. The control group and the CAPD group, they had differences in BIC component. Now, usually diagnostic criteria for defining whether BIC is affected or not, they used three methods. First was the amplitude, obviously, and second was the area of the BIC component. So if the amplitude is reduced or the latency is increased, or there's a shorter area under the curve, they termed it as BIC is affected. Second study, again Gopal and Perial in 1999. They did BIC in children at risk for CAPD. They did BIC in both MLR and ABR paradigms, and they also found that there was reduced or abnormal binaural interaction indicating deficits in central auditory process. Third study, they did binaural interaction in noise in ABR and MLR. They found that binaural interaction varies with noise levels, demonstrated importance of binaural processing in difficult listening conditions. So now what they are trying to do is they are trying to assess binaural interaction and separation together. So binaural separation or auditory closure can be used. It is a process where if there is a noise present in the contralateral ear, it helps us to understand speech. And they found a difference that as the noise level increases, they find reduced amplitudes. Similarly, in LLR, behavioral binaural interaction in auditory evoke potentials. So in this also it was found that the first study which is there, they found that BIC LLR is present at 145 milliseconds with reduced amplitude compared to some monaural responses. So overall, every test in every study says that BIC is useful and can be assessed using electrophysiological tests. We'll move forward. So this is the waveform from the same study. Here we can see the right and left combined waveform and the binaural responses. They have subtracted it and got the value. Similarly, in LLR, they have found, but the LLR component, if we see the amplitude which we see, is lesser as compared to MLR amplitude. So, spectral and temporal processing. Now, here, as I mentioned earlier, if we manipulate our stimulus and recording parameters, we can assess various things from a particular test. We'll see why I am focusing on this slide. So usually frequency following response, when we say, so there are various studies. Now here we have to be very careful in taking what type of stimulus we are using to assess the FFR or record FFR. FFR gives us very useful information when it comes to temporal processing or spectral processing. So there are various components which can be assessed. That is the latency or the F0, F1 and F2 values. Objective measures can also be used like phasogram or other things where we compare the F0, F1, F2 values of the population which we are assessing to the normal population and we see whether the process is affected or not. Also, delayed latencies say that there is a temporal processing issue in CAPD population. So if we see first study, Krishnan et al., FFR encoding of speech and pitch, they recorded speech to ABR using syllables, analyzed phase blocking in fundamental frequency and harmonics, that is the F0, F1, F2, and the latency values. They told that FFR accurately reflects spectral or and temporal aspects of speech deficits. These are linked to CAPD-like perception problems. Now, there are various studies on FFR which are done on people or children having language-based learning problems or phonological disorders, which are directly correlated to the CAPD. So, if we see the second study, they compared children with learning problem and normal population. They recorded FFR using TAW and analyzed spectral, that is the formant values, and the temporal encoding. They found that FFR amplitudes for formant frequencies were poor in the affected population, that is problem with learning disorders, and it was good in people with the control group. Third studies, FFR in phonological disorders. Again, they found the same thing: increased latency of FFR waves and reduced slope, that is impaired temporal precision and neural symmetry. Frequency discrimination can also be done using FFR. They compared behavioral frequency discrimination with FFR using pure tones, analyzed neural representations of frequency differences. So here what they did was, they recorded FFR using 1000 Hz and 1500 Hz supposedly, and they checked the F0, F1 and F2 values, whether they were different or not. And similar thing was done using behavioral test, and they compared that. So if we found a frequency difference in the F0, F1, F2 values, we say that person is identifying the frequency difference. So MMN. What we usually do in MMN, now all the potentials which we are going to see are endogenous potentials. They require attention, and we have to be very careful in what stimulus we are using. So what we can do is, I will summarize you the table. But before that, what we can do is we can ask you what oddball paradigms can be used to assess a particular thing. So supposedly if we want to assess temporal ordering or temporal sequencing, what can be used in any one table? We'll continue with the presentation. So MMN in CAPD. CAPD children, the first study which is there, they have done MMN CAPD children, where clinical population of CAPD children versus the control group was done, and they used frequency and duration variants. So what they did was they used two frequency modulations where 1000 Hz, 1050 Hz ka frequency ka deviation was used, and they were presented, and they wanted to assess whether LLR, that is P1, P2 or P1N1, P2N2 complex was obtained or not. There is a waveform. So this is the waveform from this same study. Here the dotted line represents the CAPD wala group, or upper wala represents control group. They have used other paradigms also, that is non-verbal and verbal as the Taylor stimulus. And we can see that when we use the verbal wala part, there is no clear P2 or N1 present. It is like a one complex in people who have CAPD. And there is a clear P1, N1 and P2, N2 seen in normal people. Also, they have used three methods to diagnose, or we can say compare. First one is based on latency, second one area, and third is amplitude. So we can see that maximum difference is found when we use area wala diagnosis ka method. Second, cortical responses and MMN CAPD. They use passive oddball paradigm, that is verbal and non-verbal stimulus, and they recorded MMN along with cortical auditory potentials, that is P1 N1 and P2 N2 complex. They also found that CAPD children showed abnormal cortical responses and altered MMN as compared to normal children. Third study, MMN and psychometric correlation CAPD. Multi-deviant MMN paradigm in preschool children was done, that is CAPD versus normal people. They found reduced incidence of MMN CAPD group, suggested impaired auditory discrimination and temporal resolution problems in CAPD children. Third one, fourth study, also the same thing which they have done, MMN using frequency, duration and temporal changes to elicit MMN without active attention. So here, usually there are three components to P300, P3A and P3B. Other thing, MMN, why you require attention to see whether you are identifying, or the person who is there is identifying the oddball paradigm. So they have not used active attention, and they have made the participant just sit there and record the MMN. They saw that MMN amplitude decreases and latency increases in many disorders. This reflects deficits in temporal discrimination, sensory memory and neural typing. Acoustic chain complex. Here, what we have to see is that we are using two different stimulus with varying frequency, duration, intensity, or what our motive is, as in what we have to assess. And we are trying to record two LLRs in one time frame. So how does it look? I'll show you here. So this is the first stimulus ka LLR. So there are two stimulus used. First stimulus ka LLR we got P1 N1 and P2 N2. As soon as my second stimulus starts, there's the second LLR which is getting generated in the same time frame. So this is what we call as ACC. We'll see studies on it. Acoustic chain complex clinical implications. So they recorded P1, N1, P2 complex with changing intensity, temporal gaps, or spectral shifts. That is the first study which we have seen. ACC reflects neural discrimination of temporal changes. Second study also tried to assess temporal gaps in noise in normal versus auditory neuropathy or processing deficit population. So they had three groups. First was the normal group, second group was ANSD, and third group was APD wala, CAPD wala population. And they found that individuals with auditory disorder required longer gap durations to evoke ACC, indicates poor temporal resolution. Now your longer gaps means longer gaps between two stimuli. ACC to amplitude modulation. They recorded ACC using amplitude modulated noises, and they found that ACC amplitude and latency vary with modulation rate, demonstrating sensitivity to temporal envelope processing. So the more the difference between both the frequency of the stimuli, more earlier the ACC gets elicited is what they have found. P. Kumar et al. In 2020, he recorded ACC in children using 1000 Hz and at 6 different intensities. So one was 1001, 1002, and it increased with 1 dB steps. And it was found that behavioral DLI as well as the DLI found using ACC were both significantly larger in children with CAP processes. So this is the example where 5 words ka difference the test was done, and you can see P1 N1 and P2 N2 getting elicited where there was a difference. Similarly, here different stimuli were used, and you can see if there is no stimuli after the first one, there is no response. This study shows that normal ka behavioral and objective ka comparison. So behavioral wala CAPD में is more, and objective test also CAPD ka value is more. This is the same study ka waveform. You can see P1, N1 and N2 and the other wala stimulus ka waveform. It is in one continuation. P300 and memory. So here I like to say there are two types of memory, echoic memory and the memory which is for short term. P300 has two components, P3A and P3B. P3A comes from inactive part of our attention, and P3B is responsible for where we provide active attention. Studies have done and they tell us that if person has the auditory problems or auditory learning problems, there is a reduce in amplification or the amplitude of P300 waveforms. Our first study, they have done 29 children with CAPD and behavioral tests recorded before and after auditory training, and they have seen that significant reduction in P300 latency after the auditory training. So it can also be used as pre-therapy, mid-therapy and post-therapy का track रखने के लिए. Second study, systematic review and meta-analysis of 18 studies was done using PRISMA, that is a guideline for systematic review. APD individuals show prolonged latency and reduced amplitudes, improvement after intervention. Here, this study, we measure review of electrophysiological measures, that is P300 in age-related CAPD. And P300 is sensitive to auditory processing is what they have shown. So we consider P300 as a measure which will lead us to memory ka aspect indirectly. There is no direct correlation to P300 and memory, but there are indirect correlations which are there. Auditory closure may again, FFR are mostly used. So what we do in auditory closure is we record FFRs with contralateral or ipsilateral noises, and we try to assess the latency values at F0, F1, F2K values, and we try to compare whether in presence of noise or without presence of noise is there any difference or not. Or we can compare between two groups, that is the control group and the CAPD group. First study tells that compared good versus poor speech in noise performance and recorded FFR to speech level down. Poor SIN listeners showed weaker FFR coding, that is F0, F1 and F2, and greater timing delays. Second study, again they recorded speech evoked FFR, analyzed subcortical versus cortical contributors, and they found that stronger FFR, especially subcortical part of it, is associated with better speech noise perception, reflecting efficient closure. Third study, they recorded FFR in children with auditory or learning problems using speech stimuli compared with normal children. Children with auditory processing issues showed delayed and degraded FFR, poor neural encoding of speech, and closure deficits. Children with children with reading or CAPD-like deficits. This also includes deficits in language problems or other problems like phonological disorders and children like that. They measured FFR, timing spectral, and encoding speech sounds. Impaired children showed reduced neural synchrony and weaker speech representation, again affecting ability in speech in noise problems. So this is the take-home message. Both behavioral and electrophysiological tests can be used and they are helpful in assessment. It is not practically possible to assess every electrophysiological test as we have to move to intervention also. And we practice in regular clinics. So we have to select one test which is, supposedly there is a case or behavioral test is done. And we find that there are problems in a particular domain or particular, we can say binaural interaction or auditory closure. So we can assess that particular part using FFR or its correlated auditory lobe potential. And we can say that, okay, we have confirmed our diagnosis. What we can take to our clinics is a single recording of a particular test, supposedly FFR, tries to help us to assess various problems. We can assess binaural interaction, we can assess spectral and temporal aspects of our processes through a single test FFR, and we should apply that to our clinics. This is what I'll say. Thank you so much.
And we're just ending with our session for the day. Last talk, second last, because ma'am will also continue a little on this. Today I am very happy, firstly, to be back to my alma mater here and presenting my favorite topic, EAPR. The more and more I talk about it, the more and more I read about it, it fascinates me more, and I feel that I need more and more to dig more into it. Why do we need objective measures? We have already covered a lot of it, that importance of objective measures. We have subjective measures, we have objective measures, but when it comes to deciding the pre-candidacy for the implants, we definitely are very sure that we want to go with both subjective and objective measures. But when we have already decided that yes, the candidate is going for an implant, but what after the implant is being done? Do we all do objective measures? And if we do objective measures, do we perform all the objective measures? No. We just restrict ourselves to subjective measures, that yes, we do aided audiograms, we do link 6 speech perception, and we feel that yes, we have our results with us. But objective measures have also played an important role and now are into the picture in clinical practices also. We have ECAP, ESRT, EAPR and the cortical responses. We have reached till that level. All of these tests are easy to perform, like we do our subjective test, and does not require much of our time if we practice in our day-to-day life. I'll speak more on EAPR. It is, in basic terms, it is similar to our acoustic ABR. The difference where it comes is in the waveform, how we stimulate it, and what are the recording parameters and that way. Otherwise, it is very similar to our acoustic ABR. If we have hands on the acoustic ABR, it is easy to understand the electrical ABR. So electrically elicited synchronous physiological response from the auditory nerve to the structures in the brainstem, and it is a measure of the ABR using an electrical stimulus. The purpose of this test is to identify or to check if the auditory nerve is responding to the electrical stimulus as expected. It also helps us to check the integrity of the electrode array. It also helps us during the surgery, pre-surgery and post-surgery. When I talk about pre-surgery, I here talk about transtympanic electrically evoked brainstem response. When I talk about during the surgery, that helps us to check, to determine if the electrodes have been placed appropriately. Are the electrodes working? And when I talk about if the electrode has been placed correctly or not, here I specifically mean about the ABI, that is the auditory brainstem implant, because the difference between a CI and an ABI is that of a paddle electrode, and that it does not have something to hold on, it is on the surface. So how do I assure that yes, the electrode has been placed correctly, and yes, it is stimulating correctly. So that ways it helps us during the surgery. And when I talk post EAPR, I'll move as I move with the presentation. So when I talk about the TTE APR, it is an effective clinical procedure which can help us decide whether we have to go for an implant or not. If yes, which implant should we go, whether it should be cochlear implant or an auditory brainstem implant, and it thus providing a valuable tool for selection. The first picture that we see here is we have hair cells. When the stimulus is provided, so hair cells are there, you get a response. There is a response. Here there is no response, no hair cells. So even if there is stimulus which is going, we are not able to get any response. Here I place a situation of a TEAPR where we have placed a golf electrode. I place electrode here and I check if there is a response or no response. So those are the three images that we have seen here. When I talk about TTE-ABR, a very good article and a very good article by Kumaran 2019. They have provided us with information right from where and how should the electrode be placed, how will be the waveforms, and how can we classify the waveforms, and when we have responses, whether the waveform is a good waveform, should we go ahead, is it a good TTABR response or a poor TTABR response. So under a short general anesthesia, a myringotomy is performed to identify the round window niche. The ground electrode is a subdermal electrode which is placed under the skin on the ipsilateral temporal region, and the stimulus electrode is a golf club electrode on the round window niche, which is given of a biphasic pulse, current pulse, and the stimuli is at the rate of 11 per second. With pulse width of 100 to 150, we use all the alternating and the reverse polarities are being used. So this is the golf club electrode which is placed inside around the round window niche. This is how we can place the electrode, the inverting, non-inverting and the ground electrode. Likewise, this is type A classified by Kumar and Dutt, where you have very good waveforms. As you see, you have beautiful wave 5 with robust wave morphology, and it is you have replicable peak 3 and peak 5, and the latency is within 5 milliseconds. Then there is type B, where you have again good wave morphology, replicable peak 5 but not peak 3, and the latencies are again within 5 milliseconds. As you can see here, wave 5 very much replicable, but if you see and compare the first picture to the second one, you can see the difference. Here the wave 5 is very robust versus the second one. Likewise, type C, here it is fair, and to consider it as a response, we can take, yes, this is a response, but visualize it with type A. You will see a difference that yes, the wave which was there in type A versus C is poor. And last, type D, where you have poor or absence of wave 5. So if I have something like this, I will not consider, or I will not suggest that yes, we can go for implant, or because this is not a response, and although I am stimulating it, I am not getting anything here. Versus if I go for type C, I still have a response. I can still take that risk that yes, I would get some output from here. Now that I was talking, we spoke about pre-EBR, now the post. The difference here from conventional ABR to the EABR is that in EABR we bypass the cochlear nerve and directly stimulate the cochlear nucleus. So the wave that corresponds is the wave 3 corresponds to our the wave 1 in EABR corresponds to the wave 3 of the acoustic ABR. Likewise, 4 to 2 and 3 to 5. These are the stimulus parameters and the recording parameters for EABR. This is the setup. Here, the trigger cable is very important because that is the connection between the stimulating box, the interface, and the recording device. So that is very important here. When we connect the trigger, that is how the loop is completed and we get a response. The stimulating window for EABR. This is how the entire setup looks in. Likewise, the image that was shown, very similar to that, just labeled it wave 1, wave 3, wave 4, wave 5 and 6 and 7. We generally see wave 5 and 3 when we are performing an EABR. Very rare is that we will be able to identify wave 4. If we have good wave 5, we consider it as response. Now, how will you consider that yes, it is a good response, or yes, that it is a response? How will you identify? Like we identify in our acoustic ABR, similarly for our EABR, it should be replicable. The wave morphology should resemble that of an acoustic ABR. It is very similar like that. Peak latency should be 1 to 1.5 milliseconds earlier than the ABR, and the EMG activity should not have an abnormal increase when we are increasing the current level. These are the few waveforms that these data I've collected, and this is by me only. So this is an example of the acoustic ABR we can have a reference to that of an EABR and CI and ABR. The very this kind of graph that we are seeing is the stimulus artifact. This is not a wave, and right after that what we see is our waves. So we have in cochlear implantees still we have good wave morphologies. You get to see 3, 5, which is wave 1, 2 and 3 of our EABR. In ABI cases, again this is the stimulus artifact. We have wave 1 and we have wave 3, that is wave 3 and wave 5 of our acoustic area. In ABI cases, many a times when we stimulate more, or if continuous stimulus is being provided, there are I have observed that once there was a response, the response starts to fade away, and what I see later is just noise. So that also happens. So in those cases, we need to give staggered stimuli. We cannot continuously keep on our recording going on, because you'll be like, first I had a response and I do not have a response now, and you will question yourself that first that I got a response, was it actually a response or I just marked something? But that is not the case. Over the time when I kept on seeing cases like that, I understood that yes, it is not because that was a response or not, but because of the continuous stimulus that was provided. Again in this, so this is completely no response, although we see something here, but that is no response at all. This is very clearly as we see noise, and then yes, this is a good response. These waves are replicating within earlier 1 millisecond, 1.5 milliseconds, and wave morphology is also good. This again data is being collected by me on my throughout my dissertation journey. We classified the waveforms as P1, P2, P3 and P4 in ABI cases, where we found out that the latencies range from 0.6 to 6.67, wherein we have seen that P4 usually ranges from 3 to 6 milliseconds, and those are non-auditory responses which look like this. Those are very large waveforms with very large morphologies, and that we have also correlated behaviorally. When these kind of waveforms were present behaviorally, we have observed eye twitches, facial twitches, twitches in the neck area, forearms. So all this was observed when we got waveforms like this. We also classified the waveforms into 3 categories based on their morphology as auditory, non-auditory and mixed, wherein auditory is pure when we have seen our wave 1, 3, 1, 3, non-auditory clearly that I explained, and mixed wherein we have auditory as well as non-auditory responses. These waveforms have also helped us to map the cases, where we have mapped the cases based on these waveforms over the time, or even after, if I map the case today and if I take a follow-up after a week based on these waveforms that I have done the mapping, then I have seen changes behaviorally also. In summary, this is what we have found out, that when we have our subjective and the objective measure, I'm going to put EABR. This is how the table looks like. On my findings, why is EABR important? Deciding the pre-candidacy to which implant should we go for, if the electrode has been placed appropriately or not, if the electrode is working or non-working, to set map levels. Also, if I have an EABR or TTABR done previously, and when I do first switch on, those data will also help me to set the first map. To identify cases of wherein we have non-watery responses, to further set the map levels based on that. These are a few articles that I would like to mention. These are my references. Also, I would like to thank, and if you all have time, please go through my classmate's dissertation also. Sejal has also done few work on EABR. Her dissertation was also very good on the EABR topic. Thank you my alma mater, SASLP, Merck Institute of Speech and Hearing, my mentors, my friends, and my family. Thank you.
We are running quite late, so I will restrict my. Mostly it is more like a concluding presentation because now we've gone through so many different aspects and uses of auditory evoked potentials. What Aditi spoke about was AEPs for assessing. So what Aditi spoke about was AEPs used for rehabilitation. And I will talk about a few other AEPs, that is auditory evoked potentials, and how they can be used in rehabilitation. Thank you all for a wonderful presentation, especially Aditi talking about EABR. Before this starts, cortical auditory evoked potentials are responses that are evoked from the auditory cortex. It includes LLR, MMN, P300, and so on. The beautiful advantage of cortical auditory evoked potentials is, since we are using longer duration stimuli, and since we have a larger time window, we are able to do a lot with the stimulus and the responses, and also we are able to get aided and CI-assisted responses using CAPs. And although aided ASR, aided MLRs are also tried, aided FFRs are also tried. So far in the past many years that I've been reading about evoked potentials, LLR and CAPs in general are, in my opinion, the best to assess benefits from any kind of hearing device or cochlear implant as well. Okay, so I'm going to keep this very short. CAPs are used for estimating hearing thresholds. Yes, again, the beautiful advantage is that we can get beautiful frequency specificity using LLRs, which we cannot get using chirps or tone bursts as well, because we have the opportunity now to use longer duration of stimuli which will prevent spectral spasm. Assessing severity of ANSD, like Kutsia spoke about. Measuring outcome with hearing aids, determining cochlear implant candidacy, ear selection, benefit from the cochlear implant, benefit with the training. Assessing auditory processing that Riya just spoke about, and monitoring any kind of changes in terms of neuroplasticity. So I will not get into details about all of it. I have included information about MMN and P300 as well. We'll see if we can share the notes to you. I have spoken about mensuration of CAPs initially, and since we are very short of time, I'm sorry, I'll have to go ahead. Yes, so we have a few cases which we have done CAPs for. for cochlear implantation in children. So especially this has been very useful to us in cases with cochlear nerve abnormalities or deficiencies, and also to see development or progress across a few years after the hearing device is fitted, like as hearing age progresses and as auditory training is continuing. So this is an article of Anjan's previous article where MATA and GAR stimuli were used before in a person with hearing impairment and after using hearing aids. So I'll just briefly go through a few of these. And when it comes to monitoring benefit from hearing devices and selecting hearing aids or the next option, are we able to give enough access with the hearing aid? Are we, should we go for a bilateral option, or is the bimodal option doing well? So this paper we have done assessment with bimodal fitting, that is hearing aid in 1 year, CI in 1 year, only CI and only hearing aid. A lot of individuals did show better responses with CI and even better responses with bimodal devices, except for one trial that we have. There are also studies which talk about differences in early versus late implanted children as to how the CAEPs should catch up. So this is one of our data with an early implanted and a late implanted child. Here you can see a lot of noise and the CAEPs are not really catching up. So this is a child with bilateral simultaneous CI, bimodal amplification. And this particular case, Vanajam had seen this case. This was a child with MRI showing absent or small caliber auditory nerve, and we had to do progressive behavioral testing as well as LLRs to see, because her responses were very inconsistent, because there were times when we used to see very clear indication that there might be a response. So after a few months, we were able to do a year selection and she could go for cochlear implant, although the prognosis was guarded. I will move ahead and skip this part and go to my take-home message. So in terms of AAPs, especially CAAPs, everyone can do it. What do you need? We don't need to supplement evaluations, but we need any AAP instrument capable of modifying stimulus parameters, which most AAP instruments are able to do. ECOG kit if you want, insert earphones, headphones, and for aided and CI assisted CAPs, speakers are very essential. P300 mm modules are included in many AAPs, but are also optional if you don't want to do it. But we have in personal experience, we have had a good experience using P300 or MMN to understand more about is the child able to differentiate between sounds, how good is the discrimination, and is this being associated with speech perception. And more than anything, we need to identify the need and potential and for which AAP. Like Aditya has found out that she can work in EABR. Shruti ma'am is more experienced with ABR screening. And there is, I promise you, so much potential to work in this area, because we need a lot of children assessed over a period of time. So since we're talking about going from cradle to classroom, this is the end of the presentation, where I want to say that, auditory work potentials are for all ages. It doesn't stop at hearing screening and early identification. It is a very important start. And we do monitor children for a long period of time in terms of their, especially children with hearing loss, in terms of their access to audition and how well they are able to cope up with mainstreaming. So with this, we all thank you for your attention. I know we have exceeded the time, but I hope hope you found this presentation very useful. Thank you so much.
Thank you so much to the moderators and panelists. It was a very enriching session. Thank you for sharing your knowledge, expertise and experience. I'm sure all of us have benefited from all the information that you've given us. Any questions? I will now request Dr. Manoja ma'am to please felicitate our moderator and the panelists. Mr. Riaz. Mrs. Shruti SG. Mrs. Aditi Kothari. Ms. Kutsia Khan.